Good evening, everyone. My name is Martin Trope, and I'm very pleased to be talking to you this evening or this afternoon, wherever you are, about a new series of technologies which we believe is going to fundamentally change the way we do endodontics clinically, and as a result will result in a better biological outcome. We're talking about endodontics in this hour, and of course we're aiming for the best success we can. And I just want to point out that the definition of success, or the way we look at success in endodontics, has changed fundamentally in the last 10 years, maybe, probably in reaction to implants and how the implant community defined their success. I was in academics for almost 25 years, and we focused almost exclusively on what we call academic success today, which means no detectable disease. So, there's a whole series of outcome studies where you look at a tooth. It may or may not have a lesion, and in 5 years' time, is it asymptomatic, and is the lesion still present, or has it disappeared? And that would be called a successful case. But now we are much more focused on functionality as well. We're not diminishing biological success, but we also look at functionality. So if a tooth functions without clinical symptoms, we can use that as our definition of success. Of course, we're aiming for both: no detectable disease and a tooth that is functioning well without any clinical symptoms. So when we look at no detectable disease or academic success, we're basically talking about microbial control. If it's a vital tooth, we don't expect microbes to start, and our main focus is to keep the microbes out and to fill the root canal and put a good top filling on there without allowing microbes to contaminate. If it's a tooth like the one below, where there's a radiolucency, we assume that the root canal system is infected, and after our root canal treatment, we would want no detectable disease, assuming, of course, and expecting that the patient has no clinical symptoms, and that would be called a successful case. Now, when we talk about functionality or survivability, this is related to the amount of tooth structure that is remaining after the root canal treatment. So it's quite reasonable to expect that we can get a better microbial control the more tooth structure we remove. But at the same time, while we're removing tooth structure, we're weakening the tooth, and that may jeopardize the ability of the tooth to function over the lifespan of the patient. So obviously, the aim ultimately is to remove or prevent as many microbes as possible while removing as little natural tooth structure as possible or as necessary. So we try all the time to balance these two requirements, where we get a maximum microbial control with a minimum of dentin removal. Not one at the expense of the other, but taking both into consideration. Now, as we stand today, we have a problem in our technology in order to achieve these two aims. And if you look at this CBCT, you will notice, I'm sorry, I'm going to go to the previous one. This is supposed to be, and there we have it. You'll notice once we go in a cross-sectional area, at no time is this root canal or any of these three root canals round. They're always oval-shaped and sometimes extremely wide in one dimension and narrow in another dimension. And the problem here is that whatever file you use, and of course every company comes to you and they say, if you use our file, you know, your troubles will be over and everything in your life will be perfect. But basically what the end result is a round shape. So you've got a canal that at no time is round, and the technology that we use creates a round shape. And that creates a problem in that either we are going to remove too much dentin in order to clean this non-round canal with a round file, or we're going to have to minimize dentin removal and then result in less microbial control. So this really leaves us in a no-win situation, and this has been our problem forever, really, because nickel titanium files were a tremendous advance in technology, but at the same time, after the use of nickel titanium files, the same as stainless steel files, you still ended up with the same round shape. And here's a very good example of what I'm talking about. This was a lateral incisor instrumented to size 60. And when our student saw that this is failing, she made the calculation, if you will, that size 60 was the maximal safe size that was possible, and it was not worth retreating this tooth. So she went for a surgical approach. And those of you who do surgery see this all the time. Here is the cross-section of the root having been resected. And what you see is the size 60 is very adequate in a mesiodistal dimension, which is the dimension that the X-ray comes from, or the direction that the X-ray comes from. So in the mesiodistal dimension, this root canal looks very, very well filled. But in the buccolingual dimension, which is the dimension we don't see on the radiograph, I would say not even half of the root canal is filled, and it's quite understandable, if you will, looking at this picture, why this treatment failed. All these untreated areas are filled with necrotic infected tissue, and that is absolutely no barrier to sustaining an inflammation in the periorbicular tissues. So obviously, the conclusion could be that no, you need to make a round shape according to the largest diameter, not the smallest diameter, but then of course you're going to run out of root mesially and distally and jeopardize the functional survivability of this tooth. So it really is a very, very difficult dilemma, and really with the technology as we have it today, an unwinnable situation, if you will. So if we look at a diagram of a typical root canal, we've got a more oval canal than round, and we've got a dentin surface around it, which mimics the shape of the root canal. So we got a choice of instrumenting to the minimal diameter. And of course, that's very attractive because, number one, the X-ray is going to come from this side and it's going to look adequate on the X-ray. Since you're instrumenting it to the minimal diameter, you're less likely to make mistakes, if you will, less likely to perforate, ledge, etc., etc. So this is attractive, but obviously not adequate from a biological point of view, since if this is filled with microbes or even vital tissue, which are potential a source of substrate for microbes when the root canal is done, this is not the ideal situation. Now, as I mentioned before, looking at that surgical case, we cannot pick the biggest diameter because that's clinically unacceptable, and you run out of dentin on the thin side, and functionality is not a possibility. Now, what we've been doing with our philosophy, wherever I've been, I was in North Carolina, I'm at Penn, we always used to go for the maximal safe apical sizes. What that meant was we go to the largest size so we can clean the canal as best as possible and try to do the least amount of damage possible, and also acknowledge that the ability to clean the full surface of the root canal is not possible in many, many cases. So we did the best we possibly could, but we acknowledged that we weakened the tooth slightly, and we did not clean from a microbiological point of view optimally. Now, obviously, the best is to clean the canal in its entirety, and only the canal, and leave the dentin in its entirety, and leave it as thick as possible and as strong as possible. And as I said before, we feel that we have technologies today which can get closer, maybe even completely achieve those two aims. So this is not the only story with traditional round nickel titanium files. Another problem is that when you have curvatures in the root canal, we get the illusion, or we have the illusion, that if we move the file above the root canal, you know, with our hands or our handpiece, that we are moving the file in the direction that we move our handpiece. But this is actually not true. What happens is the file bounces off the curvatures, and you will get, you know, where you started up top, moving to the middle, then going to the other side, and moving again to the other side, whipping around, but never actually cleaning the canal entirely. Here is a plastic 3D produced tooth. It's a real reproduction of a tooth, and excuse me, you can see that they're round shapes with a lot of untreated areas, and where there is a curvature, there's an additional problem that the file will tend to go to the inner aspect of the canal and rarely come close to the inner curvature. So this is a major problem with a round file. One of the most underestimated or underappreciated problems with a file, and particularly now that we're tending to use less and less files to do more and more in the root canal, is that when a file is used, any file, stainless steel file, nickel titanium file, when the file is used, it creates a tremendous amount of dentin. I mean, the file is cutting dentin in order to widen the canal. Now, we get the illusion that all the dentin is coming out coronally because we see quite a bit of dentin on the coronal aspect as we look down into the canal or into the chamber, and also we see a lot of dentin on the file. But in fact, the first place the dentinal chips go is anywhere where there's space. So if you look at your left-hand picture here, you can imagine that the file is here, so no dentin will go there because the file is taking up all the space. But the dentin is pushed into this area here and packed very, very, very tight. And you see here again the same thing, dentin packed in each area here, and very, very, very tight. And this is a problem because that is not only dentin, it's also bacteria, organic, inorganic material, substrate for bacteria, so that when maybe even an adjunctive technology comes in, let's use, for example, ultrasonics, which we use as a secondary and last irrigation adjunct to get into the irregular areas, this packed dentin will not allow the irrigant, will not allow anything to get in there, and will also make it very, very difficult to clean that area. This area is packed very, very tight. So in fact, what the file is doing, it's creating a round shape and sort of entombing itself within that round shape. And that means that everything else in the irregularities cannot be easily removed, and that jeopardizes our long-term success. If you look at a picture like this is a cross-cut of a mesial root of a lower molar. You see the two round shapes of where the canal has been treated, the main canals in a round shape, right? But here is the area that's very, very difficult to get to. So in these areas, first of all, we would like a technology that can clean the natural shape a little bit better. In our dreams, we would like these two to join, but let's say that's not going to be exactly possible. But we'd like to clean a little bit better. The problem, in addition to the round shape, when we go back to the traditional files, is that this area again gets packed very, very tight with dentin. And now if we were to come with an adjunctive irrigant, with ultrasonics, with sonic, with negative pressure, all these common adjuncts that are sold to get into the irregular areas, those adjunctive methods are limited because they cannot get the irrigant through this packed dentin. So this is really a tremendous problem and an unappreciated problem with the traditional round files. So let's look at a possible solution and see how we can overcome this problem. So what I'm talking about and what I want to present to you is a new way to clean the root canal. This has just been brought onto the market by Brasler. It's called the XP3D Shaper, which is one file, and then that's followed with the XP3D Finisher, which is the adjunctive method equivalent to maybe an ultrasonic, where the walls are actually scraped and cleaned from biofilm and dentinal debris and things of that nature. So in order to explain the technology adequately, we have to just look very quickly at the properties of nickel titanium alloys. And probably most of you know this, but let me just quickly go over it so that I'll be able to explain the technology a little bit better. Most of us that do endodontics with nickel titanium files know the nickel titanium files in one of its property shapes, and that is the austenite shape. And the austenite shape is the shape which has a memory. And the best way to describe that is if you have a nickel titanium file and you bend it, it is extremely flexible and you can almost bend it to any shape. But when you let it go, it comes back to its original straight shape. And that's what we've had in nickel titanium since the beginning. And the reason why we've had that shape memory austenite phase is that is the phase, that stiffer phase, is the phase that cuts dentin more efficiently. But actually, every nickel titanium alloy has another phase, which is the martensite phase, which is the softer, malleable phase. And it actually has no shape memory. So if you cool a nickel titanium alloy, what happens is it becomes like a stainless steel file, really. It's soft, you bend it, and it stays where you put it. And it won't come back to that straight original shape. Now that's a property of every nickel titanium alloy. That's good in one way. You can pre-bend, you can get it into a canal very easily. The problem is that at this martensite softer phase, it's a very poor cutter of dentin. So you'll get a martensite nickel titanium, try to cut the dentin, and the nickel titanium just stretches and loses its original shape and does very, very little in terms of cutting the dentin. Now, one thing that a lot of people don't appreciate is that the temperature at which the file is at the austenite stiffer phase or the martensite softer phase can be controlled by the company. So up to this point, most of the files were in the M phase very, very cold. So we as the practitioners never saw that phase. And at room temperature and at body temperature, it was at the austenite phase. So we thought we only had one phase. But actually, you can manipulate that, and much more modern endodontic files have actually used that. And at body temperature, at room temperature, the file's at the M phase. So you can pre-bend, you can make it malleable, you can make it like a stainless steel file. And then when the nickel titanium file goes into the body, and particularly the root canal undergoing frictional heat, then it will turn to its austenitic phase. So you have the shape memory with the austenite phase, and you bend it and it comes to its original position. And then you want to make it martensite, you could get ice. This is ice spray, and it stays in the martensite soft stage. So that just demonstrates the two. And this is a very, very nice demonstration because it's got nothing to do with endodontics. Here you have a paper clip of nickel titanium alloy. It's in the martensite form, so it's very malleable and can be made into any shape possible. And then the person in this video puts it into some warm water, which is above the austenite temperature required for this particular alloy, and you can see it immediately comes back to its original shape of the austenite. So we've got a technology now, and I won't explain what this is, but what you saw there was at the beginning, like here, it's in the martensite form, and then at body temperature, and this is just to show you with a finger that that's body temperature, it goes to its austenite phase, which is the shape it's in inside the root canal, and you then can be used at its maximum advantage. So let's look first at the technology. We have a shaper, which is to actually open the canal, and it has the ability to cut. And then you have a finisher, which I like to call a scraper, not a shaper, which cuts, but a scraper. This XP 3D finisher actually is not strong enough to cut the dentin, but has the ability to scrape the dentinal walls, and that allows it to clean the areas which are untouched and unreachable by the first file, the shaper. So let's look at the shaper first, because this is the one you use first. So let me just explain the basic file. So you see the core file. Let's say this is martensite. It is possible to get it to this shape. It's very unusual that it is in this shape, but when it's at room temperature, it's malleable. And this file has a number 30 tip with a booster tip, which I'll explain in a minute. And the taper is only 01 taper, so it's almost a parallel file. So what you have here is a very, very flexible file, which has a core minimal taper, if you will. But when the file reaches body temperature, in other words, when the file is in the root canal, it changes shape. And the shape, when there's no resistance and the file is spinning, will go to an 8% taper or an 0.8 taper. So this becomes, when there's no resistance, a 30.08. But remember, most canals that we start instrumenting are not the 30.08. So we use the booster tip, which I'll explain in a minute, to go from a 15 to a 30. And then because most canals are very narrow to start, this file, because it's so flexible, will squeeze down to a 30.01 or a 30.02, depending on the file, the original canal shape. And then once it starts to spin and it reaches body temperature, which is almost immediate, it wants to go to an 8 taper. So actually the taper is flexible, if you will, and dependent on the time of use. So if you're a practitioner like me who doesn't want to go more than an 0.4 taper because I want to maintain as much dentin as possible, I will use this file for 10 strokes. If on the other hand, you like a big taper and you want to use a vertical condensation technique, then you could go for 30 or 40 strokes, and that will allow the file to expand, to overcome the resistance of the dentin, and to increase the taper. So we generally, in our philosophy, go for an 0.4 taper because we want to have biological success and as much tooth structure to maintain and allow for functional success. But as I said before, with increased use, or if the canal is naturally a bigger taper, the file will adapt to that size and that taper. So let me explain the file a little bit better by explaining the advantages. So the first advantage is at room temperature, the file is at martensite. So it's malleable, so it can be bent to any shape and can get into even the most difficult canals to get into, because you can just pre-bend that file, get it into the orifice, and as soon as it starts to spin, it's going to naturally straighten and keep inside the root canal. Now, this booster tip is very, very important and one of the most underappreciated aspects of this technology. The booster tip allows the file to go from a 1502 glide path, and I'm not going to get into this tonight because this is not a new technology, but in order to safely use this shaper, you need a glide path of at least 1502 or a 10 or 1504 if you want more of a taper. But once you have that, the file will immediately get you within 3 to 5 strokes to a 30. And this is because of the booster tip. And this is what the booster tip is. The first 1/4 of a millimeter of the booster tip is a very, very finely pointed, non-cutting blank, if you will. So this will get into, the most minimally prepared canal, an 0.8, 0.6, but we'd like you to get a glide path of a 15.15 because the file starts to cut at 0.15. And then for another 1/4 or 0.3 millimeters, you've got a 6-sided cutting burr, if you will, at a specific angle, which gets you from a 15 to a 30 within 0.3 millimeters. So once you've got your 15, the booster tip gets in. It then will cut you very quickly within 0.3 millimeters to a size 30, and then the rest of a file is a normal file, 3 cutting angles, and this could be at any taper, any shape you like. In this particular file, it's at an 0.1 taper. So this is a nice video that we made at Penn. You'll notice everything's underwater at body temperature because we have to simulate body temperature. And the plastic block, which is not really a canal, but it's the closest we can make an artificial canal. We need a glide path of a 15 or a 10 or 15 04 nickel titanium file. We, in this demonstration, are going to just use a 15K file. And then with this booster tip, within, here you have 1, 2, 3, you're down to a 30. And actually, if you use a 31 gauge needle, as we recommend, you can go all the way down to the working length within those 3 up and downs with this shaper. You get all the way to the working length. And actually, if you like a very, very conservative preparation, a 3002 will reach. Now, another advantage is we keep the flexibility of the 01 taper, but we have the capacity of a file which is an 02, 03, 04, 05, 06, 07, 08, whatever you, the practitioner, decide you want to finish at based on the time you use the file. So this is just a quick example. These are the same 30 files, but one has a taper of 00, one has a taper of 02, the other one has a taper of 04, and if you bend them with the same force, you can see, according to the taper, so the flexibility is affected by the increased taper and the increased metal mass. So here's a continuation of that video. We're at a 3002 immediately, as I said before. But now we want to increase the taper. So we're just going to use 10 additional strokes, 2 working length, long strokes. This is just to show the 3004 does not go down because the taper is not sufficient. Three, 4, 5, 6, 7, 8, 9, 10, 11, just 1 for luck. Irrigate again with the 31 gauge needle. And, oh, I'm sorry. And then the 3004 does get down. I stopped the video too early. Now, what you also have, and this is the most important, of course, is the file is adaptive to the original shape of the canal. So you've got these 3 bulges. The file is spinning, and because of the flexibility and the snake-like action of the file is going to look for the empty spaces, if you will. So the file is going to move into these empty spaces. So we're going to have less dentinal debris and less torque. Let me go back because I did not show you what I wanted to show you in the first one. So unlike the round file, this file is going to move, and it's going to find the empty spaces. And because of this movement, the snake-like movement, instead of making these round shapes and moving up and down, the file is able to clean the entire canal. Now, this is something that I stressed in the disadvantages of a round file, and I have to stress is an advantage of this file. Because the file is an 01 taper, but it's moving inside a larger canal, there's space for the debris to stay within the main canal and not be pushed into the irregularities. And this is very, very important. So unlike a normal file which is making a round shape, and very, very quickly the space is filled with debris, and the debris will be pushed wherever it can. Here the file is spinning because of its snake-like action. It's bouncing off the walls. It's causing a lot of turbulence and keeping the debris in the main canal without pushing the debris out. So because of that, if you take a reciprocating file, it will create a tremendous amount of stress based on the color change in these blocks with a light filter technique. Even with continuous rotation, less stress, but still quite a bit of stress on this canal. Now, if you look at a shaper file where the debris has stayed centered within the canal and is not pushed sideways and then can be irrigated out, there is absolutely no color change in these blocks, which means less stress, less potential for debris packing, less potential for microfractures, less potential to jeopardize functional success. So if we look at this video, this is a 3D reproduction of a real tooth. And after the glide path is gained, you can see in this upper canal here, the shaper actually does the entire job. So after 10 movements up and down, you can see the canal is basically completely clean. However, on the lower canal, you've got a lot of irregularities here that actually even the expansion of the shaper is unable to clean. So you will find that there's areas down here, there's a little divot over here that's not clean, and there's an accessory canal here that's not clean. Now, of course, it's much, much, much cleaner than any round file could do, but not absolutely perfect. So we have to use an adjunctive method in some of these canals. Now, in terms of excuse me, let me go back one. In terms of how well it cleans, you'll have to go back here, and you can see this is a preliminary study that we have the results for. And generally, I want to make the point that the general understanding is that a round file can clean about 50% or less of the original canal. Now, look at this. In this distal canal, the red is what's clean, the green is what was original. The entire canal is, I'm obviously biased, but I'll say almost perfectly cleaned. The mesial canals are wonderfully clean. However, the isthmus is not touched, right? Well, the isthmus is not touched, and of course, that's too much to ask for the shaper. But what we have to understand is, unlike the other round files, where it wouldn't clean the main canal nearly as well as this, but it would also pack debris into the isthmus. With this shaper, there is no debris in the isthmus, and so you have a chance to come with an adjunctive cleaning method and have a chance to clean this a little bit better. And here you have a study which shows that with a typical file, you get this dentinal debris stuck in the entrance to the isthmus, making the adjunctive files, adjunctive methods, much less effective. Here with the shaper, there's just one little bit of debris over there, but generally the entire canal and isthmus area is open. I'm not claiming that it cleaned this area, and the micro CT show us that it doesn't clean the area that well, but when I come with my adjunctive instruments to cause turbulence in the irrigant, I have a chance to get in there and to clean a lot better. Retreatment, I'm going to go over very, very quickly because I only have a short amount of time for this presentation, but it is an amazing retreatment instrument. I personally go to higher speed, and the reason it is so good is because of this extra space and the snake-like fashion of the shaper. The gutta percha tends to get caught in there like a worm and is easily removed. And you can see, we see this over and over again. Okay, so that's the shaper. The shaper, I would claim, does a tremendous job and a superior job to any other round file that we have on the market. However, not perfect, because it has a capacity to expand, let's say, 3 times, and some canals need more than that. So the adjunctive technology that I want to present here is the finisher, the XP 3D finisher. Now, this is the same basic technology in that the martensite form is one form, and then it gets to another shape at body temperature in the austenite form. So you've got a file which is a 2500, parallel 25, nickel titanium, extremely flexible, like spaghetti. And because it's so flexible, it does not have the ability to overcome the resistance of the dentin, even when it's in the austenite phase. And when it's in the austenite phase, it gets this sickle. And this sickle, when rotated, gives you a diameter of 3 millimeters in the bulb and 3 millimeters at the tip. However, that's not the entire story, because if the canal squeezes the bulb, the tip can expand to 6 millimeters. If the tip is squeezed tight, like in a tight canal, the bulb can expand to 6 millimeters. But just in air, it goes from a 25 capacity to a 300 capacity in terms of reach and scrapability, if you will, in scraping the canal. So here is the file spinning in air, and you can imagine the canal squeezing it down, it will expand. And if you squeeze on the tip, the bulb will expand as well. And this video here will show it a little bit better. Here's a false bulb, if you will, very wide, filled with plaster of Paris, instrumented with a round file to start. And now you see the finisher working. First of all, it scrapes all the plaster of Paris away. Then we come in and irrigate in a minute. And I want to point out how it's working. The tip is squeezed, the bulb expands. The bulb is squeezed, the tip expands. Okay? And you go up and down 7-8 millimeters, and you will get the maximal effect of this instrument. So now we come back to this 3D replication of a real tooth. Remember, the shaper cleaned this area very well, but was unable to perfectly clean the lower canal. So now we come in with the finisher, but of course clinically we don't know that the upper canal, say the mesiobuccal, is perfectly clean, so we'll still use the finisher in the upper canal. You can see how the bulb is expanding the tip and expanding itself when the tip is pinched, if you will, causing tremendous amount of turbulence. So if this was not wax, but it was an empty space, necrotic tissue, the turbulent irrigant would easily go down there. And now we go to the canal that really needs it. And you can see how by moving it up and down, it expands into that divot. And then it finds this extra canal, and by going up and down, we usually use it for 60 seconds total. I personally use 20 seconds of sodium hypochlorite, irrigate, another 20 seconds sodium hypochlorite, irrigate, and then the last with EDTA. And you can see how it's moving up and down based on how much the canal squeezes it both at the tip and at the bulb. And just a study, again, a recent study in the Journal of Endodontics, and basically showing that in terms of bacterial reduction, that's biofilm reduction, and 50 microns into the dentinal tubules, the finisher was the most effective method in microbial control. All right, I'm going to just finish off for 5 minutes with obturation, and then I'll be open for questions from the audience. Now, we have tried in this technology to have maximal kill of microbes, that's biologic success, and at the same time minimizing dentin removal to maximize functional success. Now we have to fill the root canal. And traditionally a root canal filling has a core material, which is gutta percha, which is basically just a filler, and then a sealer or cement, excuse me, which is the real resistance to dentinal microbial leakage. Now, because the sealer has two very, very serious defects, that is, number one, it shrinks on setting. These are traditional sealers. And number two, the sealers are generally soluble in tissue fluids. So these are major problems, and yet we absolutely need the sealer. So what we have done is we've created a technique where we have maximum core material, that's the gutta percha, which actually doesn't seal, it just takes up space and is inert, in order to keep the sealer as thin as possible. And from that requirement have come two of the main techniques in root canal filling: cold lateral condensation, where we just add additional points, or warm vertical condensation, which in the last 10-15 years has become very popular. Now, the problem with both of those techniques is that you need space. For the cold lateral, you need space for a spreader. For the warm vertical, you need to get your plugger to within 4 millimeters of your working length. In order to have that space, you have to remove what I like to call unnecessary dentin or dangerous dentin in terms of functional outcomes. So one of the last technologies that we have in terms of this new approach to endodontics is bioceramics in endodontics. And most people know bioceramics as MTA, which is an adaptation of Portland cement. And this is a very, very, very good material. However, the consistency does not allow it to be used as a sealer. Now, Brasler in the US has the EndoSequence brand, and these are pre-mixed bioceramic materials for putty, for pulp capping, root canal repair. You've got a flowable root repair material, and then you've got the root canal sealer, which is pre-mixed at the consistency of what we need for the perfect sealer. Now, what the advantages of this sealer are, and I can't go into it because of time, but basically, when the sealer is unset and combining with water from the root canal or wherever there's moisture, it is bioactive. It releases calcium hydroxide, has a very high pH, antibacterial and bioactive. When the sealer sets, then the material, like MTA or any pure bioceramic, is biostable. So it is stable. It actually expands slightly on setting, unlike the traditional materials which contract slightly on setting, and also does not dissolve in tissue fluids. So this is the perfect sealer. So now we can change our concept completely. We don't have to have maximum gutta percha and minimum sealer. We can have maximum sealer and just have the gutta percha as a hydraulic pump like the vertical condensation technique to move the sealer into the irregularities and also to be there for post-space, retreatment, or anything of that sort. So here's just a chart showing the traditional sealers shrink a tremendous amount, whereas the bioceramic sealer will expand just very, very slightly, increasing the seal rather than increasing the gap where the seal is present. The gutta percha also is impregnated with bioceramic nanoparticles. So the gutta percha is going to seal and bond to the sealer. So that one of the gaps that has always been a problem, the gap between the sealer and the gutta percha, where the bacteria can go and use as a highway to the apex, is closed by this nanoparticle of bioceramics combined with the sealer. On the other side, as a typical reaction of bioceramic with moisture, hydroxyapatite is formed, closing that gap. So you get really a tremendous potential seal here. So before, we always wanted maximum gutta percha and minimum sealer. Now we want minimum gutta percha and maximum sealer, which is a true paradigm shift in root canal filling. But you have to really understand when you're using this, this is not to be used like our classical sealers, where we just paint a thin wall on a thin layer on the wall. We really need to try to fill the canal with a sealer. And the results look a lot like you would expect from vertical condensation. But unlike vertical condensation, you don't need to open the coronal 2/3 so that you can get a plugger in there. So what we have here is a very well instrumented, we presume, and filled apical third, and a very minimal taper in the coronal thirds. And because of the hydraulics, we get a puff that we are used to for a hydraulic technique. And here you have a 5-year follow-up, nice healing, but the sealer does not biodegrade in the tissue fluids. And that's a very, very nice indirect indication that the sealer is not going to biodegrade in the canal as well. So the technique is very simple, really. We get our gutta percha point measured to length, and with the 3-dimensional instrumentation, that takes a little bit of trial and error, either with a traditional file or traditional gutta percha point, because remember, the shape is going to be according to the anatomy of the canal. So this, in a very narrow canal, will be a 3004 because that's what we prepared. But in some canals, they're naturally bigger, and we have to get a gutta percha that fits reasonably well. We then place the sealer into the canal with our tip. Then this is my personal bias. You could do it any other way. I put a lentular spiral 2 millimeters short, and I move the sealer down to the apical third, because you don't want vapor lock, you don't want an air bubble in the apical third. Then we place the gutta percha slowly at first, and then the last 4 millimeters with a little bit of pressure, and that moves the sealer into the irregularities. And then cut it off at the apex and you're done. And the great thing about the sealer is it's hydrophilic. So you can wash out the axis cavity with as much water as you like, and you will get no problem at all, because this sealer loves moisture. And then if you look at a cross section, what you expect to find, say in the 2 canal, is that the majority of the canal is filled with sealer, and the gutta percha there is just left as the hydraulic pump. So we have extracted teeth as examples, and we use this technique. And here you have at 1 millimeter 3 millimeters and 5 millimeters. And I particularly like the 3 millimeter picture here because what it shows me is that the canal with the shaper and the finisher mimics the shape of the root, which means that the shaper and the finisher have maintained the original anatomy of the canal. And then using this bioceramic filler, if you will, with a gutta-percha hydraulic pump, we've been able to fill the entire canal. And at the 5 millimeter where there's a isthmus, the isthmus is filled as well, presumably because no dentin was packed in this area, and the turbulence and maybe even the shaper, the finisher, I'm sorry, was able to get into that area. So this is the entire protocol, if you will. We start with a glide path. That's a different lecture completely, but we'd like to get to a 1502 stainless steel. Of course, that's the most inexpensive way to do it. But if it's a difficult canal, calcified canal, and we need a little bit of space taper, you could use a 1004, which is my preference. Some people use a 1504. There's nothing wrong with that. That's absolutely fine. And then we use the shaper. So the shaper is used 3 to 5 up and down movements to get to the working length. If you don't get to the working length, you re-irrigate, attain your glide path, and you get to your working length and you're at a 3002. And then based on your preference, you move it up and down slowly in long strokes. I do 10 up and down strokes, and 99 times over 100, I'm at a 3004. You could do more in bigger canals or more in order to get a bigger taper. And then you'd go to the finisher, and the finisher is used for a total of 60 seconds. And then it's time to fill with the gutta-percha and the bioceramic sealer, and the gutta-percha will be a minimum of 3004, but could be much larger. Okay, so that's the end of the lecture. I'm very happy to answer some questions, and I see we have some questions here. I will answer them in a minute. But please, if any of you have any questions, you can contact your local Brazler rep, but certainly I'm available at nextlevelendodontics.com, and will be very, very happy to answer any questions that you may think of afterwards. All right, so Dr. Trope, can you further explain the size limitations capabilities of the shaper? Minimum 30 prep, but up to what size? And then if larger, what is the best way to apically gauge for obturation? Okay, so let me say we have a narrow canal, less than 30. So then the shaper is going to produce, based on the booster tip and the expansion, a 30, let's say 04. But if, let's say we're dealing with an anterior, central incisor, or a distal of a lower molar, then the shaper is going to adapt to the natural shape and size of the canal. So it may be a 35 or 40 in the mesiodistal, but it could also be a 60 or 70 in the buccolingual. And because of that snake-like shape, you are going to have, say, a 35 in one dimension and a 70 in the other dimension. Now, when it comes to obturation, we want the gutta-percha obviously to stop at the cemento-dentinal junction. So I would, in a big canal, start at a 40, because the 40 is going to probably bind at the cemento-dentinal junction. But that's where I start. Now, you could start with a gutta-percha point and cut the gutta-percha points, etc. My preference is to start with a 40-04 normal round file. And then I can, go 45 or 50 or go down one and make sure. And then I'm not wasting gutta-percha or cutting gutta-percha, etc. So it really is something to get used to, that unfortunately when it comes to the gutta percha, we've still got these round gutta perchas, and we have to adapt them to the non-round canal. However, we have the bioceramic sealer, so the bioceramic sealer will take up that extra space. So as long as you use it in the way that I described, not with a very thin layer, but attempting to fill the entire canal with the sealer, and then just using the gutta percha as the hydraulic pump to move the sealer, then you'll get a very, very good fill. I hope that was adequate to answer the question. Given that the file is thinner than their analogous round files, and there is a flexure between the tip and the bulb during the working phase, is there higher potential for breakage versus other systems available? Actually, the opposite is true. Files break because of two fatigues, if you will. Cyclic fatigue, which is the up and down movement, analogous to breaking a coat hanger, if you will. And because these files are so flexible, they are very, very, very resistant to cyclic fatigue. So the way this file has the potential to break, and it very, very seldom, if ever, does, is due to torsional fatigue or tip lock, right? Where the tip does not make a full rotation, but the rest of the file does. And this is going to answer the next question on the list there. In order to overcome tip lock, we increase the speed of the file. And you'll notice, I didn't mention this, but you'll notice it on the slides, and someone has asked this question, and that is, what speed do you use them? And they have to be used at a minimum of 800. I use mine at 1,000. And the faster you go, the less chance there is that the tip is not going to make a full rotation. It will lock and you'll break the file. So in fact, these files are extremely resistant to breakage if you use them at 800 or above. As soon as you slow down, and this is the tendency of a lot of first-time users, we've been taught the slower you go, the safer it is. In fact, in this case, it's exactly the opposite. If you slow down and the file does not make a good cut, then it can break. Now, that is the shaper I'm talking about. And it used according to manufacturer's instructions, I would claim it will hardly ever break. Now, the finisher is resistant to cyclic fatigue even more than the shaper because it's even more flexible. And if you instrument to above 30, it's resistant to torsional fatigue as well because it has a size of 25. So if the canal is at least to 30, the tip is not going to lock. So the finisher will almost never break. It can be placed in at any angle, at any direction, because it's so flexible that you're not going to break it for torsional cyclic fatigue. So the next one is, what is the RPM? Can you run them at 600 RPM? No, we need to run them at least 800 RPM. That was awesome, thank you. That's the best question in the list. The shaper and finisher can be used more than once. The shaper and finisher can be used, that was a question. So the shaper, I would not use more than 4 canals, meaning 1 molar. And not because it has the potential to break, but because the expansion from martensite to austenite tends to get lost. It almost loses its power like a battery. So 4 canals, if you're talking about anterior teeth, probably maybe a few more because there's very little resistance. They're just expanding in air because these are such big canals. The finisher is also pre-sterilized and made for 1 tooth. But the truth is, if you put the finisher in a warm water above body temperature and it regains its shape, that sickle shape, it probably can be used again. I just want to step back one point. I use my used shapers, not finishers. I use shapers for retreatment. Because for retreatment, we're not really worrying about full expansion. If it lost its bit of its power, you know, battery power, etc., the gutta percha will still come out like a worm. So I use my shapers that have been used more than 4 canals for one retreatment. And I spin my retreatment even at 1500, 2000 RPM, and it works absolutely fantastically. When you have a radiolucency, how do you avoid the overfill? You know, like any other canal, any other root canal instrumentation, you make sure that your gutta percha is short of the radiographic apex at the cemento-dentinal junction. Okay, that's the end of the seminar. I hope that you enjoyed it. I'm sorry I didn't get to all the questions. Remember, you can contact me at nextlevelendodontics.com. And, you know, I can't see any of you, but I hope that this was informative. Thank you very much.